really stood out.
He like above and beyond, like and never said no, like never like even hesitated,
I was really
like
impressed.
even took some initiative to say like I'll do
Yeah,
that, like
I was thinking I was gonna ask this kid. He was just like, I was like, that's why I was so impressed with his
yeah,
career. Like, oh, he did it. It's like I didn't ask.
no, me too,
Yeah.
yeah,
Okay, perfect.
okay. Are we introducing ourselves? Yes.
I feel like we would have to, right?
Okay.
Like,
Hi, everybody. We're going to get started. Um, uh, so, hi. I'm Dr. Jacqueline Harris. I think most of you know me or have seen me. This is Dr. Rowena Eng. Most of you know or have seen her. We're from Kennedy Krieger and Johns Hopkins in Baltimore. And we're going to talk to you a little bit about the neurodevelopmental profile of Wiedemann-Steiner syndrome, and then some of the research we have done and are doing in this area. So we are going to start by just reviewing an overview of the neurodevelopmental profile associated with Wiedemann-Steiner syndrome. We're going to talk more about the specific neuropsychological phenotype that is associated with WSS. And then we're going to discuss some trends in some features that we see kind of common to Wiedemann-Steiner syndrome. Because of course, every person, whether they have WSS or not, are different and have different profiles of strengths and weaknesses, but there are some things that are really specific to the syndrome, and those are the things that we're really interested in understanding more about and learning more about. And then we're also going to talk to you a little bit about how Wiedemann-Steiner syndrome and these specific profiles that we're finding compare and contrast to other syndromes, kind of its sister or cousin syndromes. So the first thing we're going to do is review the overall, give you a broad overview of the neurodevelopmental profile of Wiedemann-Steiner syndrome. So just as some background, neurodevelopmental disabilities are diagnoses that are descriptions of symptoms or descriptions of features. So these are things like autism, intellectual disability, ADHD, anxiety, cerebral palsy, things like that. And again, these are diagnoses, but they are diagnoses in that they're descriptions of features that we see outwardly in the adult or child, and they don't really tell us anything about the underlying cause. And so what is important to note is that Wiedemann-Steiner syndrome causes these neurodevelopmental disabilities. So a lot of times our kids get lots and lots of diagnoses, and some families come to us and say, well, is my kid just super unlucky? How did we get Wiedemann-Steiner syndrome and intellectual disability and anxiety and all of these things? And the answer is no, that's not what happened. What happened is your kid got Wiedemann-Steiner syndrome. Wiedemann-Steiner syndrome results in brain dysfunction, and brain dysfunction manifests in lots of these different ways that we use to describe it. And for syndromes and neurodevelopmental disabilities in general, overlap and multiple diagnoses are the rule, not the exception. And the reason for that is because a developing brain does not develop in a vacuum. So it's not even like a brain disorder like you think of an older adult who has a stroke and it affects one little thing that has one specific area. A developing brain that is impacted by a genetic disorder is impacted in pretty much every area. And so you see multiple different things. However, even though I've just said it affects, most areas of brain development, what we still know is that certain genetic syndromes or genetic changes actually lead to certain patterns of brain dysfunction. And again, everybody's a little bit different within these, but these are general patterns or rules that we see many kids with different syndromes follow. And so here are some examples of patterns of cognitive strengths and weaknesses that have already been published associated with certain genetic syndromes. You know, some have more or less anxiety, some have intellectual disability, some may not, some have language more impaired, and others may have other things more impaired. And so one thing that we want to know is, or wanted to know, is does Wiedemann-Steiner syndrome have a particular phenotype? Phenotype means the symptoms that are outwardly displayed. So are there particular things in the neurologic or the cognitive or the behavioral profile that we know? And prior to a couple years ago, the descriptions of this actual specific profile in Wiedemann-Steiner syndrome were really limited to non-existent, meaning there were reports that said, oh, it's associated with developmental delays or behavioral problems, but those really tell us nothing, right? What does that actually mean? And so what we set out to do is figure out more about this. So we know that there was a pretty broad range of kind of the intellectual disability spectrum. So what was described was anything from mild to severe intellectual disability, lots of anxiety, lots of executive functioning issues, and maybe some autistic features. We're going to get more into that. And then there are these behavioral issues, and we knew that these behavioral issues were leading to adaptive functioning that's lower than would be predicted by the cognition. So what does that mean? That means that even though your child or adult with Wiedemann-Steiner syndrome may test at a certain kind of IQ level that says this is their cognitive capacity, the way that they function out in the world may be less than we expect based on that IQ because of some of the anxiety and the executive functioning issues that we see. Poor sleep, even after the obstructive sleep apnea may be corrected, which obstructive sleep apnea is nearly universal in this syndrome. And then early hypotonia that improves with age but never goes away. Seizures are more common in the general population, but still an uncommon presentation. And about half of patients have a minor finding on brain MRI, but brain MRIs are generally not something we recommend universally for these patients because it doesn't make that much of a difference. And there is an increased risk of spine abnormalities, both on the lower spine and the upper spine that we do see. And so going through the neurologic features, hypotonia. So hypotonia means low muscle tone or kind of loosey-goosey, super flexible kind of muscle tone. And it's present, according to the 2021 study, it's present in about 73% of people with Wiedemann-Steiner syndrome. Even this is almost certainly an underreporting, right? Hypotonia is kind of a subjective measure where you just kind of pick up the baby or move around the kid's limbs and say, are they loose or not? And a lot of people, especially non-neurologists, might not report it, but we think it's a nearly universal symptom. It can result in delayed acquisition of motor milestones and balance and coordination issues. And more than half of patients with Wiedemann-Steiner have a delay in walking, but even without that, other issues, balance and coordination issues, poor fine motor skills, this persists. The treatment is physical and occupational therapy. It does improve with age, but it always stays an issue. And the certain types of genetic variants, so the ones we call loss of function or truncating variants, more commonly have more hypotonia than other variants. So brain MRI findings, again, about half of people with WSS have something reported on their brain MRI if you read the report, but almost all are mild findings with no clinical significance. And, so again, this is not something we standardly recommend. And usually lots of parents get a brain MRI, they get the report back, and they're like, oh my gosh, what is this? But it's usually nothing to worry about. So definitely talk to your physician about whether or not this has any impact, because most of the time it's kind of true, but not causative, right? Meaning the Wiedemann-Steiner syndrome causes these little brain abnormalities. It also causes cognitive and behavioral impairment, but there's not a relationship between the brain abnormalities and the cognitive and behavioral impairment. Spine anomalies, there is abnormal development of the lower part and often skeletally the upper part of the spinal cord and vertebral column. In more severe cases, it can be, it could lead to actual problems like a tethered cord or something like that. This is a question that I get asked all the time. Potty training issues in Wiedemann-Steiner syndrome are common. They're very, very common. Very, very rarely are the potty training issues actually because of a tethered cord. That said, it's worth talking to your physician about it just to make sure, but it is very uncommon. Again, usually there are potty training issues because of Wiedemann-Steiner syndrome and a number of things associated with it, and it's not directly related to any tethered cord. Seizures occur at about 20% of people with Wiedemann-Steiner syndrome. Possibly more common with those in a missense variant, but we're really not sure on that. Some of the newest data kind of contradicts that statement. We don't know any more specifics about types of seizures, types of EEG patterns, specific treatments. There's one paper out there on seizures and Wiedemann-Steiner syndrome, but it basically says that you could see all kinds of different things on the EEG and on the seizures. And one thing that we are interested in is, does seizures in any way, does the presence of seizures impact the cognitive functioning? So this is just a little plug. If there are families out there who have never participated with us and your child has seizures, we are interested in talking to you a little bit more, so come and see us. Cognitively, in earlier studies, it was quoted that 30 to 60% of Wiedemann-Steiner kids and adults with Wiedemann-Steiner syndrome have cognitive issues. This is not true, right? It is 100% of kids with Wiedemann-Steiner syndrome. It doesn't, you know, it may not be severe enough to be labeled as intellectual disability, but there is no one out there with Wiedemann-Steiner syndrome whose cognition is not at all impacted by the presence of WSS. So in a more recent study, the 2021 one with 104 patients, 97% of the patients had either intellectual disability or an early diagnosis of global developmental delay. So again, this is closer to the true number, right? And then those 3% in there, that doesn't mean they don't have any cognitive issues. It just means it's not labeled as intellectual disability or global developmental delay. Most of the individuals that we see with Wiedemann-Steiner syndrome and that we've described are in the mild intellectual disability range, but a few are scattered lower. And again, one of the things that we're very interested in is trying to figure out why there are those differences and understand that a little bit more. A very small study suggested some autistic features and communication issues. We're going to talk more about our studies that are a little bit larger and, you know, powered directly to look at this question. Did I go wrong? I went the wrong way, sorry. Okay, so this is a little bit of an understanding of when we use these categories, when we talk about mild, moderate, severe intellectual disability, or borderline. Some of you all hear that too. That means your cutoff is just a little bit above the intellectual disability range. This is sort of general expectations for what we see in this type of intellectual disability. So people with a mild intellectual disability usually kind of top out, right, at a mental age of about 10 years old, give or take, when they're adults, right? So 10, 11-year-olds can do lots of things, okay? 10, 11-year-olds can mostly take care of themselves, be independent as far as their activities of daily living, get themselves dressed and undressed. You wouldn't send an 11-year-old to the bank to negotiate for a mortgage, right? So this is where we talk about independent living with support for those with mild intellectual disability and even those with kind of borderline cognitive problems. Something that is important to note in Wiedemann-Steiner syndrome is what we talked about before. So Wiedemann-Steiner syndrome, unlike other causes of intellectual disability, has these very specific behavioral features, mainly looking like anxiety and ADHD, which we're going to get a little bit more into that, but that actually impact that previous chart I showed you. Meaning that even though their cognitive age looks like a mild ID or borderline or things like that, often their functional age is a little bit lower, especially if the anxiety and the ADHD is not kind of optimally treated. And so earlier studies suggest these behavioral issues are present in 40 to 70%. Again, not true, right? We have studied this enormously and we think it is much higher, again, approaching 100%, although of course there are some who are worse and have worse of these behavior issues and some who have better. Almost all of them exhibit these kind of features. And frequently in the families that we talk to, these behavioral issues, more than the medical issues, more than the cognitive issues, are the things that the families would fix. If I could just get this anxiety under control, if I could just get this impulsivity under control, things would be a little bit better. Anxiety and ADHD together with cognitive issues is the rule, not the exception. And yes, in our experience, the worst performance on adaptive functioning, we just talked about that. So also behavioral sleep issues. So we already know that more than 3/4 of individuals with Wiedemann-Steiner syndrome have obstructive sleep apnea, often requiring their tonsils and adenoids out. That's very, very common. But it is important to know that for most kids with WSS, the sleep issues do not stop there. So half or more of kids with WSS have sleep issues that persist beyond just the sleep apnea. And these are kind of behavioral sleep issues, right? These are things like difficulty falling asleep, difficulty staying asleep, difficulty getting good sleep when you are asleep. And these could be very, very impactful. So there's more to sleep than breathing. Anxiety. So we see every type of anxiety in Wiedemann-Steiner syndrome, everything from generalized anxiety to specific phobias, and it is frequently very, very severe, okay? The most common type of anxiety that we see often tends to be two things. One is kind of a separation anxiety, and Dr. Eng's going to talk about this a little bit more, where you have a difficult time separating from a preferred person or caregiver, and then also kind of an OCD type of anxiety where you are unable to, we call it kind of intolerance to uncertainty, where you don't like to not know what's going on, and it leads to asking the same questions over and over and over again, or talking about the same things over and over again, liking routines, and this often becomes more severe later. So a lot of times we see families come in and say, I don't think they started puberty yet, but we're at like 10, 11 and things are going crazy. What is going on? And we do think that it's ramping up as they get older. And environmental issues like being in the wrong classroom setting at school can definitely worsen this. Structure is very helpful, and it should be treated in a multifaceted way with combinations of therapy, education plans, and most of the time medication. ADHD and executive dysfunction is nearly as common as anxiety in Wiedemann-Steiner syndrome. It's often more apparent in the younger kids than the anxiety is, again, because the anxiety ramps up over time. The executive function is kind of there from jump. Anxiety and ADHD can kind of play off of each other and worsen each other, both symptomatically and also when you're trialing medications to treat them, right? And so, and executive dysfunction and ADHD is not only about hyperactivity or poor focus, right? It's also about impulsivity, poor organizational skills, emotional lability. Those kinds of things are a part of this as well. And what we suggest is that ADHD be treated like ADHD would be treated in a person without Wiedemann-Steiner syndrome. So with accommodations at school and stimulant medication being first line, I will say, based on the last slides, that most of my kids and adults with Wiedemann-Steiner syndrome are on 3 medications. They are on SSRIs for anxiety, often at very high doses. They are on a stimulant for the kind of attention, focus, and really all of the ADHD features, but then they're also often on an alpha-adrenergic, which is like clonidine or guanfacine, to help with some of that impulsivity and regulation of that. So what do we think the neurodevelopmental profile of Wiedemann-Steiner looks like? Well, we think intellectual disability, yes, usually mild, but with some scattered lower. Language disability, not so much, right? There are definitely kids with language disability, and in fact, most kids with Wiedemann-Steiner syndrome have language impaired in some ways, but when you look at the comparison between their language skills and their other skills, language usually comes out much ahead of many of their other skills. Visual spatial problems, absolutely. ADHD and anxiety, absolutely. Autistic features, yes and no. It's a very specific profile that's a little bit different, actually quite a bit different than kind of typical or idiopathic autism, and Dr. Eng's going to talk a little bit more about that. Seizures, yes, more common than in the general population, but definitely not the most common features. And hypotonia, yes. So why are we even doing this? Why is this important? Well, it's important for kind of 2 buckets. One is for the clinical care of patients with Wiedemann-Steiner syndrome. This helps give you information so you can anticipate what's coming next. Think about personalized medicine, saying we know this or that or the other works better for anxiety, ADHD, seizures, whatever the case may be in Wiedemann-Steiner syndrome. And then the second bucket is scientific knowledge and research. This is how understanding these things is how we create outcome measures for potential clinical trials coming down the road in Wiedemann-Steiner syndrome. It's how we develop new treatments because it gives us an idea of how this KMT2A change is actually related to specific functions or dysfunctions in the brain and gives us an understanding of what do we need to target. So we think it's pretty important to think about this kind of thing. So clinical care, from a clinical care perspective, this helps to provide prognostic information, like what's going to happen in the future, transition planning as you get to different transitions in life, including the one from childhood to adulthood, therapy recommendations, what types of therapy would best benefit the kiddos at any certain point and what can you take a break from, screening for any comorbidities, and then specific recommendations for IEPs and things like that. And then from a research perspective, we're thinking about clinical trials, and a well-designed clinical trial, one of the things it must have is appropriate outcome measures. Outcome measures is how we know whether or not something is working. So I would not think it was good science or good medicine to go and give your child a drug that I think might work in Wiedemann-Steiner syndrome, send you home, and then call you in 6 months and say, hey, are they better? Well, what does that mean, right? What does better look like? How much better is better enough? What specific things are we looking for to be better? So those are what we mean when we talk about outcome measures. And in order to get a good outcome measure, we need to actually design it, right? We can't just say, oh, this looks good, let's stick it in here. That leads to bad outcomes in clinical trials. And people are chuckling, but believe me, that's what's been done in many, many, many clinical trials in neurodevelopmental syndromes, and it works out poorly. And so this is why we do what we do. So what we're trying to do is create the potential for excellent clinical trials in Wiedemann-Steiner syndrome in the future. So we are targeting the neurodevelopmental issues, and so we're using all of the research that we ask you all to participate in to design these outcome measures and make them really specific to the things that are universal and important in Wiedemann-Steiner syndrome. We're validating it, meaning we're asking you to sometimes participate over and over again, and that's because we want to know that these measures are going to change because we did something good with a therapy, not because they're just not very good measures and we change over time. We want to design biomarkers. So those of you who gave blood here, those of you who have come to Baltimore and given blood or done our EEG, that's what we're trying to look for. Those are things that help a clinical trial be more successful. And it also helps us, which Dr. Eng is going to talk to you more about, think about, because Wiedemann-Steiner syndrome is a very rare disease, right? So unfortunately, the reality of the situation is there are not 30 biopharm companies out there right now saying, all right, let's find a drug for Wiedemann-Steiner syndrome. That is not cost effective for them. But if we can find Wiedemann-Steiner syndrome plus multiple of its cousin or sister disorders that we could pair together in a clinical trial, that suddenly becomes way more appealing for the industry community. And so we want to look at that as well.
Right. So next, I'm just going to be talking a little bit.
Sorry.
Next, I'm just going to be talking a little bit more about specifically the neuropsychological phenotype associated with WSS. So neuropsychological phenotypes includes kind of cognition and behavior, and doing this a little bit more fine-tuned way. So again, like Dr. Harris mentioned, prior to 2022, literature on the neuropsychological profile of WSS is very limited. Most were based on kind of case reports or large cohort studies of kind of looking at medical chart reviews and based on past diagnoses. But then there poses a problem of like mixed measures in terms of how we're thinking about if they're clinically diagnosed and what measurements were being used in order for these diagnoses. And so when we think about cognition in WSS, again, intellectual disability and developmental delay is common, often more mild or severity for intellectual disability, but how does this really diagnosis capture the strengths and weaknesses? And that's often a common question we get from families when we think about like planning for school, and then also just thinking about like areas for focus, especially if we're thinking about having so much limited time for intervention services. So prior to 2022, again, like the first paper that really described any kind of more fine-tuned cognitions in WSS was suggested that verbal skills may be better than nonverbal skills, but this was based on one patient. Behavioral issues that are common to WSS also tells us that there might be potentially more executive dysfunction. So executive functions are a kind of big term, umbrella term for more goal-oriented behaviors. And goal-oriented behaviors includes things like short-term memory, being able to self-monitor, task or inhibition, planning, organizations. These are all skills that are necessary for us to really kind of make goals and set towards those goals. And so what I always tell families, someone can have intact cognitive functioning on all other aspects. If you have a really kind of difficult or have really extreme challenges like executive functioning, you can have a really difficult time displaying those cognitive strengths, even if you have them, because you can't really kind of regulate yourself enough to be able to demonstrate your strengths. Okay? And then there's really no literature at all about learning academics. So like when family comes in, they ask about well, what do we know about schooling? And that was a big, large question, right? So lots of the areas to potentially look at. Again, behaviors tend to be one of the areas that are most debilitating or what families reported as most debilitating. Dr. Harris mentioned there's high levels of anxiety that tends to oftentimes manifest more over time, which in part is, when you're an adult, you can also verbalize some of that anxiety more. But there's oftentimes, universally, we see some degree of attention and impulsivity problems. And again, these are common in ADHD diagnoses. And we do see a lot of families who report a lot of autism-related behaviors, but this tends to be a lot of the repetitive behaviors and inflexibility in routines and changes in their environment. Unlike oftentimes more of the idiopathic or other forms of autism, kids with WSS oftentimes are very highly social, if anything, overly social, and really have a hard time respecting boundaries. And so we do see this kind of unique kind of social profile specific to WSS that's not necessarily, even for those who are supposedly diagnosed with autism, than what we would typically see in some other children with autism. Again, adaptive behaviors are more like independent life skills, are often severely affected, and they're usually a lot less developed than their cognitive development. I'm not gonna go too much in this because Dr. Harrison talked about this a little bit, but like thinking about, why we need to think about like characterizing kind of these cognitive phenotypes of disorders of epigenetic machinery. We think about like that we need to prognostically, like what we think about for the future for children. How can we personalize treatment for the child so that's more unique to the syndrome? And then also, again, thinking about therapeutic targets. What can we use to measure for any kind of treatments? And then there's also this general basic science of understanding what does the impact of this epigenetic regulator impacted in WSS can do in terms of the brain development generally. And I'm not going to go too much in depth in this either, but like, there are a lot of emergent findings, and Dr. Bjornson's here, so like he leads a lot of these research, but like about thinking about the promise of epigenetic therapies and suggesting like that some of these syndromes, including WSS, can be treated postnatally and functions can be recovered. And so again, like, when we see this in more research in terms of thinking about like animal models of these syndromes, it then gives us it helps us kind of think about like, we should not now start to think about how can we get into clinical trial readiness. And one of the big components of clinical trial readiness is for us to be able to really understand a syndrome itself and understand what are the unique, robust areas that specifically impact in the syndrome that can help us move towards thinking about identifying the markers. And then, so with this in mind, like our first study, and a lot of families here participated in our initial study in 2022, which we held up to date, but like was really to first give a more robust and fine-tuned comb of really what the WSS cognitive phenotype, the manifestations look like by applying traditional kind of neuropsychological tools that are standardized and used the same way across all children. Because again, prior studies identify and give these diagnoses, right? We don't know how those are measured, and so that we don't know how sensitive those are as well. Then second was to kind of delineate if there's a behavioral profile associated with WSS that are common with other disorders associated with a similar family of KMT genes that's affected in WSS, and or what are what are common features, and also what are unique features specific to WSS. So we underwent a prospective data collection. So we had been testing children and having families come over, children and adults, since 2022, our last conference, so many of you guys might have participated last time as well, where we had families come in for 1 or 2 visits, and they completed over 3 hours of testing, and we had about 26 kids who were at least involved in the data presented here, where we had tested them robustly across cognitive measures, including like verbal skills, language, spatial processing, attention, executive functioning across multiple domains. And so here, the figure here, the yellow the green represents children who are broadly performing, broadly average. The yellow are the children who are performing below average, and the red who are severely affected. So like thinking about with like less than second percentile. When we think about less than second percentile, it means that when you're 100 children there in the same room, your child is performing in the second, all the children are in order, your child is like the second person in that line, okay? And generally what we see here is that when we look at across all the verbal kind of measures, verbal reasoning skills compared to nonverbal visual spatial skills, we see that there's this consistency of where we see visual perception, spatial perception, visual motor integration or visual construction skills. These are all much more affected than verbal skills or language skills in children with WSS. And we see this also like, when we sometimes family ask about like, well, early childhood children might have some delays in like speech or language, and like how does this later on manifest this pattern? And that generally it seems like that children make more gains in the verbal and language skills over time, whereas there seems to be more of an early plateauing in the nonverbal kind of the spatial processing component, okay? Then when we looked at even like learning and memory more specifically, so how children are able to learn new stimuli and help them over time, we see this again, similar pattern where again, you see more green, so more kind of like more intact verbal skills, whereas again, there's more consistency in the visual kind of spatial processing domain that seems affected when we think about learning and memory. So their ability to retain information and learn kind of visual spatial information, okay? So again, this is about 75 to 90% of our sample that were performing below average to impaired range for the immediate and delayed kind of visual spatial learning and memory. Here. And so another trend that we observed in our sample was that generally when compared to their overall IQ and also verbal skills, another area that was almost universally affected was executive functioning and attention. And so when we look at the kind of the bars on the right side where you see lots of red, lots of yellow, very low green, those are all kind of working memory, executive functioning skills. So working memory is what we think about short-term memory, inhibition, and perseveration behaviors. So like how perseverative they are. And again, this when we think about perseverative behaviors in testing, how that manifests in real life, in everyday life, is like thinking about inflexibility in the way that you approach things. So you kind of approach problem solving the same way. You have to be very routine-based and kind of sticks to the same kind of approach to things. And again, when we think about executive functioning and attention compared to verbal and IQ skill, like overall, they're much significantly weaker individually as well. So as a whole cohort and individually looking at each participant's pattern. And they were almost the same in terms of the same degree of difficulty as their nonverbal or visual spatial skills. So again, these two areas being much more affected than verbal reasoning and language skills development. And then we also, one of the things that we want to kind of keep in mind is that cognitive testing doesn't always manifest in the same way in real life. And so like sometimes, for example, like, parents might say like children might actually test better in testing, but when we ask parents about executive functioning behaviors in an interview, they're like, they struggle so much more. And so we do wanted to make sure that we have a measure for families to also report about their children in day-to-day life, how they're seeing their child interact in terms of behavior skills, okay? And again, when we ask families complete questionnaires about executive functioning skills, a majority of our sample were also reporting clinically significant challenges in this area. And this is kind of like the most area that's being affected tends to be more behavior regulation and emotion regulation. So this includes things like inhibition, impulse control, and being inflexible, inability kind of like being able to kind of adjust or adapt to situations. These areas seems to be very much more affected in children with WSS more broadly. So this tells us that, not only are what we're seeing it in a performance-based measures, but this seems to be impacting things on a regular basis on real-world behaviors. We did also look at, in terms of like thinking about more screening for more of the academics, because there's always so many questions about that. And so we had parents fill out generally about what they're observing in terms of academics in their children. And in the red square there when you see higher scores, so this is a grading inventory that parents have about like their child's kind of reading skills, math skills, and spatial skills. So thinking about like their ability to apply spatial skills in day-to-day life. Higher ratings reflect much more difficulty, whereas lower ratings towards the left reflects less difficulties. And again, almost more kind of universally, you see this kind of skewed trend of where most families are reporting significant math challenges, significant spatial difficulties that they're observing in school, whereas reading tends to be kind of more of a large variability. And so when we see our families more on a clinical basis, we oftentimes see almost universally that children are having some struggles with math. Most having math difficulties more than others. Some might be having equivalently with reading, if you think there's much more some variability with reading. But math and spatial skills seems to be universally affected in children in WSS. And what does this mean? So like when we think about math, right, does this mean arithmetic? And we're really talking about the basics in math, the fundamentals in math. Like so we gave, this is kind of a measure of like math number sense. So it's looking at approximate number system. It's not even really math, but the sense of if you understand quantity. So if you understand what has more or less. So children did a computerized kind of task of where they did 5 minutes of trying to let us know if there's more yellow dots and blue dots. The idea is, can you get the sense of like quantity, which has more? And this typically are starting to develop in early elementary school very early on. And when we think about like the scores we get from this, we get this kind of what we call like a Weber fraction score, but basically anything above that red line are children who are have such difficulty that they're beyond what they can, like, the norms are in that measure, basically. But what we tend to see is that children who are testing much more difficult with the math sense, early math sense, are also the same children who are having much more of this visual spatial difficulties. So there seems to be some kind of relationship between the two, which makes sense because a lot of our early math sense is also kind of based on kind of our perception numbers, right? So our mental kind of manipulation. So those children in the circle being much more affected in math tend to be also more affected in the visual spatial kind of domain as well. And same thing, what we're seeing is that executive functioning also impact math skills. So that children who tend to be performing, showing much more early, and these are children who we actually only tested children from 8 and I think up to 23, so young adults, and they're all normed for 5-year-olds. So this is a measures for like originally adapted for a 5-year-old. And this is, again, children are struggling significantly with understanding the same quantitative values, so same sense of quantity, and again, like when we looked at the relationship with executive functioning, children who have more working memory or executive functioning difficulties tend to be those who are also showing much more difficulties with understanding math concepts. They're early, because these are more fundamental early math concepts. We also see in a unique kind of social profile in WSS as well that we often don't see in some of the other kind of neurodevelopmental disorders. But what we tend to see with those with WSS is that there seems to be an interesting kind of like high social affinity, again, a very strong social drive, paired with a very strong, also repetitive and inflexible behavior tendencies. So like there are a lot of kind of like tendency to kind of like to have this kind of repetitive kind of way that they approach things, may have a repetitive asking questions, and having difficulties making friends or like actually kind of more long-term relationships or friendships, but a very strong interest in making friends, wanting to initiate interactions with other people, but often in an inappropriate way. And when we looked at a questionnaire that parents complete that are typical, usually looking at children for autism, again, the area that seems to be actually more preserved in kids with in WSS is actually the social drive. And like, so they tend to be actually scoring in more of the typical range for like having more pro-social behaviors, having that social interest and motivation to like engage. But again, like paired with a very high kind of like repetitive behaviors and inflexibility in how they approach things. Right there. So again, that just kind of reflects, again, the white bar reflects all the children who are kind of scoring in the typical range for kind of like a social interest, and the gray being, the very dark gray being those who are scoring atypically. And again, like most children are kind of much more motivated and much more kind of have an unusual kind of hyper social drive. When we look at more of the social cognition, so thinking about like their interest in engaging in other people. So in 2022, when some of the families came with, children came with us for testing, they had done a kind of computerized measure of where they're looking to see that they're interested to approach different faces that were already standardized or developed in with other and have been researched in other neurodevelopmental disorders. These faces were kind of looked pre-scored in high trusting or low trusting phases. And again, children, when we looked at this associated with executive functioning, it seems again, like executive functioning seems to also impact social behaviors, where those children who seems to not really get the same social cognition tends to be the children who are much more also dysexecutive. So like the children who are having much more executive functioning difficulties are the children who are having more difficult time perceiving these social cues and applying it in the way that they're applying in behaviors, basically, how they're going to interact with people. See. So, well, when we looked at the behavior, kind of like, when we want to think about the behavioral phenotype of WSS, we also wanted to kind of explore more, like generally thinking about what are some of the kind of symptoms that our parents are reporting. And so we gave same questionnaires to all the 26 families who completed them. And again, like about 83% of the families were reporting that their children are scoring in a clinically significant range for anxiety problems, and 63% were reporting problems with ADHD symptoms. And so again, we think that there's these kind of, when we think about like these two areas that are these are probably much more typically affected in children, and you know, like these are only the ones that are clinically significant. So we didn't even include children who are kind of in the gray area, who are more in the, who are thinking, we think about in the borderline-ish range, okay. And so overall, again, we're seeing that there's children with WSS seem to have a lot of more visual spatial challenges with the general relative sparing of verbal skills. And this kind of are consistent with what we're thinking of like concerns for hippocampal dysfunction when we think about some of the animal models with of KMT2A loss of function. So thinking about that in animal models of like the gene being affected that are typically affected in WSS. And executive functioning problems, particularly in working memory, cognitive flexibility, set shifting, and impulse control are oftentimes more commonly affected in kids with WSS. As you saw earlier, over like 90% of our kids tested in below average to impaired range in these areas. Again, these are also consistent with what we see in animal models with KMT2A seems to be involved in the prefrontal cortex development. So prefrontal cortex being the part of the area that are responsible for these functions. Again, we see a universal kind of more attention, anxiety, and kind of more dysregulated behaviors in children in WSS are being reported. And many are presenting like children with autism, but they're not really typical kind of presentation as autism either. So like they might meet the clinical cutoff, but when you actually look at them more fine-tuned, they have a lot of kind of differences and like a social interest than the kids with autism, which is something that we want to think about when we're thinking about schooling and placement for children in schooling. And so I'm just going to briefly go over some of the other trends that we're seeing so far in more of a pilot studies when we compare children with WSS compared to another disorder caused by another, a cousin syndrome, where a gene of the same another syndrome caused by a variant in the same gene family, so a KMT2 family as well. So Dr. Harris does lots of research here on this, and also Dr. Bjornstein, but on Kabuki syndrome. I'm not going to go too much in depth about Kabuki syndrome, but overall Kabuki syndrome is also caused by a variant in the KMT2D gene, which is part of the KMT family. So thinking about a very similar protein structure and function as the KMT2A when we think about what's being implicated in WSS. Okay. And again, Kabuki syndrome is often also associated with mild to moderate intellectual disability, anxiety and attention problems, and also visual construction difficulties. So some literature that already kind of suggests to us that potentially there might be some overlap. And so when we actually looked at data together on some of these kiddos, we compared those with WSS with those with Kabuki syndrome and controls. So controls being children who have similar cognitive level of functioning as those children with Kabuki syndrome. When we looked, so thinking of children with a similar kind of range of intellectual disability, but without both WSS or KS, generally those with WSS and Kabuki syndrome are both showing similar trends, that they're both significantly weaker in visual processing, visual motor skills compared to those in controls. And also, like when we think about spatial perception, they're also much more underdeveloped or showing much more challenges in these areas than other children, again, with intellectual disability without the same syndrome. So it seems to be specific to these two disorders. And then when we think about like looking at behaviors, again, across WSS and Kabuki syndrome, we see that there's a very elevated trend of ADHD having internalizing behaviors. Internalizing behaviors encapsulates both kind of mood difficulties and anxiety difficulties and externalizing behaviors. But those with WSS are even more elevated compared to those with Kabuki syndrome. So thinking about this, again, sister diagnosis. Okay, or sister syndrome. So those with WSS presented with about 63% meeting clinical cutoff for like ADHD compared to about 30% for those with Kabuki syndrome. And when we looked at more specifically on executive functioning skills, because now that we know that executive functioning tends to be more affected in children with WSS, again, we see that this area seems to be commonly affected in both syndromes. About nearly half the sample of kids with Kabuki syndrome are in a clinically significant range for difficulties with executive functioning, but WSS being even more elevated than that. So like again, thinking about 80% of our sample has scoring in the elevated range for executive functioning difficulties. Okay. So generally what this suggests is that both WSS and Kabuki syndrome are showing some similar cognitive patterns of visual spatial challenges beyond controls with similar IQ level. Behaviorally, they're also very similar in that both are manifesting in a lot of anxiety, attention, and executive functioning difficulties, but this is even more prominent in those with WSS. So preliminary findings suggest that, again, there's potential shared or superimposed features across these syndromes, which then also highlights and potentially suggests that there are shared kind of disease pathogenesis or in both the Kabuki syndrome and WSS as well. So future directions, what we think about, like, one of the things that we want to focus on because of our patterns that we're finding is that we might want to focus on more specifically kind of targeting tasks and biomarkers are targeting specifically on hippocampal functions or hippocampal networks and prefrontal networks, since that our cognitive measures are suggesting these areas being more impacted. And really integrating multiple interdisciplinary methods to really identify and validate biomarkers. So thinking about how we can kind of look at cognition in relation to neurophysiological or imaging or other kind of biometrics. Let's skip some of these because we talked. And the last thing, I just want to skip a few of these, but the last thing that we want to think about too, is I think one of our next steps too is really continue kind of looking at, again, not necessarily in WSS as just as a vacuum too, but really looking at these in consideration with other syndromes that are with similar kind of gene impacted. Because again, when we think about potential shared effects, right, that also suggests that potentially shared markers and potentially shared potential treatments as well. Okay, and this is also a shameless plug to participate in research because there's a need to participate in research. This, in order for us to move towards that clinical trial readiness, is to really understand the syndrome better. So we have cognitive study going on. Many of you already know this, but we have several biomarker studies. Anyone who are in the northeast side of Baltimore, we're happy to have you here. Yeah, or wants to travel, we're happy to have you. We have EEG study going on. Dr. Harris is leading. Blood biomarker study. Some of you guys are participating here already. And again, some of you guys are participating already, getting hair samples for looking at stress biomarkers that provides clues about prefrontal and HPA axis. So think about stress regulations. Okay. And then we just want to thank the WSS for supporting our research and all the families who have been participating in our research, at EDRC over at KKI, and Dr. Bjornson, and also Phil and Lauren. If you guys have not seen them running around testing children, they've been here long days helping us with all the research studies going on here. And happy for us to answer any questions for families now.
So Dr. Harris and Dr. Ng, we're still live streaming because we have 2 questions that came up when we polled our community. So we're going to ask those and then the live stream will come down. Okay. So the first question is, what are really the practical learning and teaching strategies that you think are most helpful for our children with WSS based on your research?
Okay. I think I always tell families, even despite the math difficulties, I think the first thing that I really think we get better hold of is often the attention and executive functioning. Really, like when children have really difficulties with managing their behaviors and attention and anxiety, no matter what interventions you give them, you're not just making the most effective use out of them, just because they have a harder time participating and getting most out of the therapies. So I oftentimes think that I think often our approach is trying to get the ADHD, the anxiety better managed first, and then we think about the other kind of more specific about math skills and more of the kind of academic programming. Other pieces I think about, in terms of like math, that just tends to be an area that tends to be lifelong, more challenging. There's really no way to correct it. That's an area that we see even to adulthood children who have been having special education schooling that just tends to be harder for. It's really helping them to adapt their weakness in real life settings. So how can we work around that weakness, teach them life skills that despite these challenges with calculation and things like that, they can still try to go hold a job and things like that, and they still be participating in a community without that impact and repeating them in that way.
And just to tag on to that, what that also functionally means, right, is that for most kids, there's never anything 100%, but for most kids with WSS, there is a point often it's pre-high school, but sometimes into high school, where like you can give all the accommodations and we can manage the executive function and the anxiety and things like that as much as we can, but that math, that kind of age appropriate math, if you will, it isn't going to happen. So the school really needs to work with you, especially if your child is on a diploma track. If your child's on a certificate track and they're still not working with you, we have a whole other conversation to have. But if your child's on a diploma track, oftentimes the school is just going to need to work with you, because there isn't very many Wiedemann Steiner kids that we've ever met who are going to really actually pass 12th grade math, like show competency there. And so it needs to be something that is considered.
And then also I heard both of you talk about handwriting versus typing.
Yeah, so I mean, we typically recommend from very early on what we call handwriting circumvention methods. So what that means is, when you're thinking about school, there are a few ways that you can do things, right? One is you could continue to accommodate and therapize and do all these things to get the kids to write with a pen, okay? That's option number one. Option number two is you can say, this is unlikely to happen in a way that is particularly functional, right? So meaning, we want kids with WSS to be able to write their name so that they could sign forms and things. Most of them can, right? Beyond that, writing with a pen is not going to likely be the most effective method for them to do written communication. And so we recommend from very, very early on that you start to work with other methods like typing, like talk to text, like other things that are not handwriting, to get them to do the work they need to do.
Thank you for that. The next question, I think you started answering, but at what age do you see anyone with a diagnosis of WSS start to plateau in some of their skills? You mentioned it around math, but other skills.
So like when we, so when we, actually the part of the reason when I gave that slide about like math, like that measure using 5-year-old norms, is because across the age of, when we looked at some of our clinical kind of evaluations of families with WSS and looked at across children across school age to adulthood, sometimes children are like, the average was that they were kind of around to the 5 to 7 year old mark for some of the math skills in terms of performance level. And I think, like, you know, individually it varies. I think like, but I think the part, I always tell families that they're still going to make gains, right? But it's just the gains, it's just going to be much more smaller increments compared to others. So like, for example, like sometimes families are like, you know, like, I just don't know why, like the reading seems to be like fine, but like their math, we just keep on doing the same thing. We do so much hours after work, they get frustrated. We spend hours and hours for tutoring, and it's like not moving that needle that much, right? And like, and sometimes my advice is also to be like, it might just, yeah, don't do it. Like, I think we need to kind of be able to step back and make sure that, one, learning is still fun for a child, and two, is that we're not over therapizing them or over intervention, so where they're kind of feeling like they're being that in just full time all the time too, right? And so like, I think providing some motivation in engaging some of the therapies is probably one of the best bets to also get them more likely to be engaged in the learning component for academics too. But in terms of, yeah, like for math skills specifically, we see that tend to kind of trend, I would say, like to like very early elementary age is kind of is where it kind of plateaus off.
But for the rest of the skills, right, they keep developing, right? And so kids with Wiedemann Steiner, as far as when do they plateau other than math and visual spatial, the answer is at the same time as everyone else does, right? Because this is a common misunderstanding. If you really think about it for a second, and you're thinking about development, a 30-year-old person is not developmentally different than a 50-year-old person. Certainly a 50-year-old person has more wisdom and, you know, things like that, but there isn't different in capacity, right? There isn't something that a 50-year-old can do that a 30-year-old cannot from a cognitive perspective. And people with intellectual disability and WSS are no different than that. The difference is, when you are following a trajectory that is lower developmentally, a smaller slope than someone who is typically developing. When you reach that plateau point towards, high teens, adulthood, right? You are just at a different kind of developmental level, and that's where you stay. And just like Dr. Eng said, you continue to gain new skills and learn new things, but you're not developmentally different, meaning you don't have different capacity for learning than you did earlier on.
I lied, there is actually one more question. So in the context of behavioral difficulties, what's your advice for families as they engage their education teams around describing those behaviors in the context of intellectual disability, autism, spectrum disorder, or ADHD? It's
some of this is person specific, right? You should have a school plan, an IEP that is specific to your individual child. That said, there are some things that we could say about people with Wiedemann-Steiner syndrome. One, we've already talked about, it's the math, right? We're not going to keep ramming our heads into a wall. We're going to be reasonable about this. Two is pretty much all kids with Wiedemann-Steiner syndrome, as Dr. Eng showed you, have executive dysfunction. So these kind of things in an IEP that in the United States we call 504 type accommodations, which is like preferential seating in the classroom and longer time to complete things and a quiet space to work, less distractions, all of these things like that need to be implemented. For the anxiety, the biggest thing that kids with Wiedemann-Steiner benefit from in the school setting is structure and routine and help with transitions, meaning kids with Wiedemann-Steiner syndrome do not do well if you just rip them from one activity to another activity without them knowing what's going to happen. I think most people in this room would agree that our people with Wiedemann-Steiner syndrome really like to know what's going to happen, right? They really like to talk about that, and so preparing them for that and then meeting that expectation is going to be really important. And then from the autism perspective, we just say be really careful and thoughtful about classroom settings. And what we mean by that is that kids with Wiedemann-Steiner syndrome often benefit from similar behavioral supports to those with autism, such as the transitions and things that I've just talked about, some ABA type therapies where you work on specific behavioral things. But the way that they are different is they are extremely what we call pro-social, meaning they really like other people. They really want to be around other people. Now, please note, that is different than successfully carrying out those social interactions, right? Those are two different things, right? That said, they want that social interaction. So what we say is be careful putting them in a classroom with a whole bunch of people with typical or idiopathic autism, because many of those kids have absolutely no desire for social interaction. And so you're going to have these super social kids who want to talk to and hug and be around everybody in a classroom of people who want you far, far, far away from them. And that might not be the best match. Sometimes it is. Sometimes there are other kids in there like them. Sometimes they're not. So,